All right, welcome everyone. In this explainer, we're going to break down everything you as a pharmacist need to know about managing endometriosis. And trust me, it's a condition you're definitely going to see in your day-to-day practice. So here's what we've got on tap. We're going to start with what endometriosis actually is and why it can be so tricky to diagnose. Then we'll jump into the nitty-gritty of pharmacotherapy, covering both pain and infertility. And we'll wrap it all up with some super practical counseling points you can start using right away. Okay, first things first, let's really get a handle on the clinical picture of endometriosis. Because, everything we do from a therapy standpoint is built on this foundation. So check this out. We're talking about a condition that affects a huge number of women, somewhere between 10 and 15% of those in their reproductive years. This is not some rare, obscure disease. It's common, it's chronic, and it's why a lot of patients are coming to your pharmacy looking for help. So what's actually happening here? Well, at its core, you've got this tissue that's a lot like the uterine lining, but it's growing outside the uterus. Imagine it on the ovaries or other places it shouldn't be. Every month, it acts like it's supposed to, but since it's in the wrong spot, it just leads to this chronic inflammation. And that is what causes the intense pain our patients are dealing with. Okay, let's talk about diagnosis, because this is a really important piece of the puzzle. For a lot of patients, just getting a name for their pain is a long, super frustrating journey. And I think understanding that journey is so key for us to provide truly empathetic care. It's not uncommon for a patient to have been suffering for years before they walk into your pharmacy with a diagnosis. And there are a few big reasons why. First, the symptoms can look a lot like other things, like IBS. Second, there's no simple blood test for it. Something like a CA-125 just isn't specific enough. And third, imaging, like an ultrasound, it can totally miss the smaller implants. The only way to know for sure is through laparoscopic surgery, which is obviously a huge step. So you can see why that delay happens. All right, so this brings us right to where we come in. Let's talk about our therapeutic toolkit for managing the pain that comes with endometriosis. The approach we take is really methodical, kind of like climbing a ladder. We usually follow what's called a stepped care approach. The whole idea is to start simple, right? We begin with things like NSAIDs, and we only move up to the next step, like hormonal therapies or the more powerful GnRH agents, if we really need to get the symptoms under control. Okay, step 1, NSAIDs. For milder pain, these are our go-to. But here's the absolute key counseling point. Patients need to take them on a schedule, right when symptoms start. It's not about waiting for the pain to get bad. Why? Because we're trying to get ahead of the problem. We want to block those prostaglandins that cause all the cramping and pain before they really get going. Taking it as needed is just playing catch-up. So, what happens if NSAIDs just aren't cutting it? Well, that's when we move up to the next step, which is hormonal suppression. And the first stop here, for most patients, is going to be combined hormonal contraceptives, or COCs. Now, COCs are awesome for a couple of reasons. They suppress ovulation, which helps, but the real magic for pain management is using them continuously. This can stop periods altogether, which means no more painful withdrawal bleeds. Now, of course, you'll talk about the usual side effects. But the one thing you absolutely cannot skip is counseling on the H's warning signs. We need our patients to know exactly when to seek urgent care for a potential blood clot. But what about patients who can't take estrogen? No problem. We've got progestin-only options, but they're not all the same. Let's take the depot shot. With that one, you've got to talk about the potential for bone density loss. And a really big one, the return to fertility can be delayed a lot. On the other hand, you have the IUD. It works locally, right in the uterus, so you get fewer systemic side effects. The trade-off? You need to tell patients to expect some breakthrough bleeding, especially in those first few months. All right, now we're at the top of the ladder. For that really tough, refractory pain that just isn't responding, we bring out the big guns, the GnRA agents. These are incredibly effective because they basically put the body into a temporary, reversible menopause. This low estrogen state starves the endometrial implants and causes them to shrink. But a temporary menopause, that sounds unpleasant, right? And it is. This low estrogen state comes with all those classic menopausal side effects. So that leads to a huge clinical question. How do we get the benefits of this powerful therapy without making the patient miserable? And the answer is something called add-back therapy. It's a really elegant solution. We add back just a tiny bit of hormone, not enough to restart the endometriosis, but just enough to fight off those side effects like hot flashes and, crucially, to protect their bones. This is what makes the treatment tolerable. And this is a huge counseling point for us. We need to be hammering home the importance of calcium and vitamin D to give their bones that extra support. Okay, let's completely switch gears for a minute. We've talked a lot about pain, but what about the other huge challenge with endometriosis? Infertility. This is so important because the way we treat pain and the way we approach infertility are not just different, they're often complete opposites. Think about it. The main therapies for pain, COCs, GnRH agents, what do? They stop ovulation. They are literally contraceptives. They do nothing to improve a woman's ability to get pregnant later. So when the goal is fertility, the whole playbook changes. We're looking at things like ovulation induction, maybe with off-label letrozole, or in a really interesting twist, we might use a GnRH agonist for a few months before IVF, because that's actually been shown to boost the success rates. Okay, we've covered a lot of ground, so let's boil it all down. What are the absolute must-know, high-yield counseling points that you can take from this and use with your very next patient? I know we've said it before, but I'm going to say it again because it's that important. If your patient is on a COC, you have to counsel on the H's warning signs. No exceptions. This is one of the most critical safety conversations we can have, period. Now, for those patients on a GnRH agonist, there are 3 things you need to cover. Number 1, set expectations. Be honest about the hot flashes and other menopausal side effects. Number 2, talk about bone health. Emphasize calcium and vitamin D like it's their job. And number 3, manage their long-term expectations. This treatment is amazing, but it's not a cure, and the symptoms will likely come back after they stop. So to bring it all home, let's end with 3 final pearls. First, always stress adherence. And for hormonal therapies, explain why continuous use is usually better for pain. Second, help them see this as a chronic condition. It's about management, not a one-and-done cure. And finally, and maybe most importantly, always clarify the goal. Are we fighting pain right now, or are we trying for a baby? Because you just can't do both at the same time. And that really leaves us with something to think about, right? Your role is already so vital, from explaining add-back therapy to making sure a patient's goals are clear. But as new treatments keep coming down the pipeline, the pharmacist role is only going to get bigger and more important in managing this really complex, chronic condition.